So that's
This meeting is being recorded.
lovely. We've got that then. That's great. Thank you for that. So if we just go into the sort of the first topic, I'll just do a little bit of an update in terms of the Integrated Care Board. And I think the key thing for this month is something that I know that you've all been involved in to a sort of greater or lesser degree, and that's something called enhanced access. And all enhanced access is really providing more appointments to patients in the health system that comes in on the 1st of October. So every available patient will have more opportunities to book between the hours of 6:30 and 8 o'clock, and that's Monday to Friday, and 9 to 5 on a Saturday. Now, the interesting thing is it is a new name called Enhanced Access, but we have had opportunities for people to book in terms of additional access hours, but it's just they've been done very differently in the past. And now our primary care networks, so those groups of GP practices who are working together, they will be leading on providing these increased in the number of appointments across Leicestershire and Rutland from the 1st of October, so this weekend. But just to sort of assure people, we're not turning off what we currently have in the system. And the reason we're not doing this is the same as you have with any new service. You have to wait to see how it is being used, how people are responding to it, how people are booking appointments, how they're reacting to it, to make sure that it's working for people. And also the other thing that we don't want to do is if we went out at the weekend on sort of very big bang approach on enhanced access, we do run the risk of sort of destabilizing stuff, potential of having more people calling up, and that could prevent then people from getting through. And we know it's already a busy situation with phone lines, etc. So the approach that we're taking is we're evolving this service. So no big bang at the weekend. We are taking a very sort of almost systematic approach. So we're asking at a primary care level and a practice level to start to introduce enhanced access and what you've got and the appointments that are available over the next 2 to 3 weeks in an approach where you're not going out to all patients. You're going out first of all to those patients who are vulnerable, in greatest need, and then you're working that up so that eventually the whole of your registered population knows about the service. Now, from a PPG perspective, we will be sharing what we're sharing with practices in terms of our approach around the toolkit. So we'll be letting you know around those details. But I think it was just important today to let you know that there's not going to be a mega campaign either nationally or locally. It's a very gentle approach to this, see how it actually goes first of all. And then the other consideration is that we do need to consider that in our health system, we have got 26 primary care networks. So therefore, 26 ways of actually doing things, which is another reason why we can't go out with a big bang process. And the reason why we've got 26 different ways of doing things is that the PCNs have really looked at the health needs of their population and what that means for appointments between 6:30 and 8 o'clock Monday to Friday and 9 to 5 on a Saturday. And they've really tried to tailor the provision of that service to meet local need. So I will pause there then. Burj, can you, I can't see the chat. Oh, sorry, I can't. Just to see if there are any questions. So I think I saw one come up from Alan. So Alan, do you want to put your mic on and just ask your question?
Hang on. That better?
Yeah, lovely, perfect, Alan.
Great. I sent you a copy of ours this morning that's come out.
Yeah.
And the information that's going out to patients, at least from Northwest, talks about PCNs. Patients won't understand what a PCN is.
Yeah.
So I don't know whether it's just us, but I would suggest nicely that they change it to practices within blah, blah, blah.
Yeah.
Then patients will understand what you're talking about.
Totally agree, Alan. And the sort of tool, the toolkit and the sort of covering message we're talking around that approach. So yes, I totally agree. So if I may, because you've sent me your information, I'll just send something personal to Northwest, if that's okay.
Yeah,
lovely.
I've mentioned it to our practice manager, but it would probably be good coming from you as well.
Yeah, no, that's fine. Absolutely happy to support that, Alan.
Thanks.
Thank you for that. So let me just check before I move on. So I can't see any other questions around that. So I'll go on to the next item, if I may. And if anybody's just joined, we're just moving through the agenda, but I will allow time, obviously, between each section to make sure that you can answer any question. Sorry, I've got Andy's hand up.
So it's probably worth perhaps noting as well that the way this is going to be rolled out, because I appreciate, Alan, it's a great point that you make about the patients not knowing what PCN is. I think the language used got to be very, very careful. It's got to be very, very patient friendly so that people understand what's going on. But I think we've just got to be mindful that not all these additional appointments may not be offered by the immediate local, your own practice may not be offering those appointments because it's the network offer. So that may be a little bit different to what people are used to. And we've probably got to get that message across, that it doesn't mean because there's this additionality that's coming into the system, it doesn't necessarily mean it's the individual, your immediate local practice that will be offering that. It's a sort of a collective effort, if you like.
Yes, Andy, you're right, but it does actually say now this is where they will be, and I'm assuming other PCNs will be doing the same.
Yeah. Okay. All right, lovely. Thank you for that. So as I say, as always, we'll keep you informed of that, and your feedback on this as we move along over the next few months is really going to be important, because then we can tweak our messages dependent on what your sort of reactions on the ground level are. So just the first main item then we've got here. So as many of you will know, earlier on this year, on a national scale, a company called Ipsos Mori, they do a national GP survey England-wide. And they're basically asking 63 questions about patient experiences at their practice level. Now, this isn't open to everybody. They actually target within each practice community a group of people, and it's sort of random approach to fill out the survey. Now, the results, which are publicly available, and later on in the slides, we'll share with you the link. I'm sure many of you have already sort of tapped into this, because I know that you're on the case with this. But it really does provide a lot of information about how patients have rated their experience on some really key component parts of it. And when we receive this in the health system, obviously we do further work on this, really to understand how we want to use this information locally. It is just one form of data. It's important to say that, and it has to align with a lot of other things. But in sharing it with you today, I think what we hope that you might do is use this where you have got that dialogue with your practice to sort of start that conversation if you haven't already done so. Because what we're trying to do, certainly as a system, is really to be supportive of our practices in terms of getting the solutions on stuff. So if we just go through the data, if you can move on to the trends over time, and go to the next slide. So I know none of this will be a sort of surprise to you. Just to say that of our health economy, just below 50,000 patients are invited to take part. And we had well over 40,000 patients who took that up. Now, statistically, that's around 30%. So that is a strong response back. So, we're confident in terms of the data and what it's telling us. Now, unfortunately, where we compare this nationally, we know that we are performing across Leicestershire and Rutland below the national average in the key questions in terms of both 21 and 22. But we do need to sort of put a caveat on that in looking at, when this data was collected. So for 2021, we were actually collecting that data during what was the third lockdown. And then this year, it was at that stage where we were actually transitioning and getting back to a new normal. So we do also need to kind of factor that in. And when you're having the conversations with your practice, you do need to kind of factor that in. The three areas where we trends over time are telling us that we really need to look at very carefully, and this won't be a surprise, is that ease of getting through to a GP practice on the phone, overall experience of making an appointment, and patient satisfaction with the GP appointment times. And that's in that red box. But you can also see the elements either side of that, that is saying to us that whilst we know that is difficult, when people do get through, we are scoring much higher in terms of confidence levels, being listened to, having needs met at the appointment. Now, I appreciate that if you are the person on that call at 8 o'clock in the morning trying to get through and you are not feeling well, I know that is difficult, and we don't belittle that. But again, I think it's important that we do see these in the round. And I won't steal Andy and Mel's thunder, but obviously we're doing an awful lot of work in the health system really to support the practices, and doing almost that compare and contrast, because we also know that there are a lot of practices who are performing really well, and we need to take that learning and then really be supportive of those practices who are struggling within their economy. But what I will say in terms of the sort of engagement response to this is that we're doing what we term some very hyper-local work. So along with our colleagues from quality teams, from workforce teams, from digital teams, we're going into those practices. We're trying to support them in terms of websites. We're trying to support them in terms of building relationships. We're also will be talking to the PPGs in those practices who are not performing as well as they would like, and teaming them up then with local voluntary and community organisations to say, how can we tackle this problem together? So we will be tying in you as PPGs. And then for practices generally, we have just actually started the conversations with practice managers about reinvigorating the patient participation networks. And we've got a lot of positive stuff coming back, and we're learning a lot around where practice managers want us to give support. So it's watch this space. We will be starting a Leicester, Leicestershire and Rutland wide campaign, which obviously we'll be telling you about so that you're part of that process. We just go to the next slide, and again, I'm mindful when I'm presenting what a positive insight. It isn't belittling the fact that we know that we've got problems, but we can really see here in those boxes that are highlighted in green here, that there are confidence and trust in our healthcare professionals, and people are saying, well, when we went to the practice at our last general practice appointment, our needs were met. So we have to take that in a positive light and share that best practice with people across the health system. I just also thought that it'd be useful to share some of the digital trends. If we can move on, Burge, just in the slide deck on that. We will share these slides with you afterwards, as we usually do. So if we can just go on to the next slide. So one of the questions was, which of the following general practice online services have you used in the past 12 months? And I guess it's not surprising that respondents did report a higher online GP service in 2022 than they did in 2021. And obviously that was that kind of big surge in response to COVID, to lockdowns, etc., and having to do things in a different way. In 2022, though, the most used online service was actually ordering repeat prescriptions, and we align very much to the national figure, so slightly lower, 30% here and 31% nationally. But in contrast, the second most used online service for us in this patch was booking appointments online, of which we got 16%. But it was lower than other health systems, which is quite interesting. And the least used online nationally and in our health system was actually accessing medical records. So this is showing that people aren't taking up that opportunity. We just go to the next slide, because this is talking to us about websites and the work that we need to support practices with in terms of how easy or not their website is in terms of accessing more information and services. So we've got a job to do here. We've got some people finding it very easy, but others not, finding 25% not so easy. We've not tackled that from 21 to 22. And if we are saying that we need that digital aspect to services, then clearly we need to look at that. And again, PPGs really play a part in that, in looking at your practice website from a user point of view and making that offer to practices. Well, how can we help you as well as the system to improve that? Just the other one on digital, if we go to the next slide, is just what people are doing before they actually try and get an appointment. Now, we know this wouldn't apply to everybody, because sometimes you do need an appointment, whether that's digitally or face to face. But it's also interesting to see that perhaps those people who weren't sure whether it was a definite appointment, what their thought processes was, whether they thought around other services, whether they thought maybe pharmacy, or how they could help themselves. And this is quite interesting. If we look at that left-hand column, is how many people didn't try to get any other information. Now, as I say, we have to put in the caveat, it isn't appropriate for anybody, but it really tells us a lot about how we actually are doing communication in terms of the new opportunities that GP practices now offer. And then just the next slide is just looking at how do people try to book an appointment. And we see really high in this area, not surprisingly, by phone. But we also know that people are struggling in terms of getting through on the phone. So this slide is really telling us that there are other opportunities that, if we really capture them and tell patients about them, that could really take the pressure off those people whose maybe only option is phone because they haven't got online systems in place. But really how we can use this data to sort of balance out, so we're spreading the load for people. And again, that is where you could come in and provide your advice and guidance to your practice. So I mean, just in a digital summary, just on the final slide, across LLR. So we are in the bottom grouping nationally for online GP practice services. We shouldn't take that as a negative. We should take that as we can actually, there's opportunities for us, and we need to take those by the scruff of the neck. Online GP services used within the last 12 months was the majority among respondents nationally. Generally, nationally and locally, the scores for online services increased, which is good, and as I say, not unsurprising. We do need to respond to this data in terms of GP practice websites, and again, taking the learning from those practices that were saying, well, actually the website is accessible, and then just also how we spread the load in terms of booking appointments. So if we just stop sharing the slides there, because I'm going to pause because you've heard enough from me. So I'll just go to the questions in terms of what we've got. So I think Alan, you were probably first. So if you want to ask your question.
First of all, Sue, on the primary care thing at the cricket ground, they were talking about, or I was talking about the head of comms, about the telephone systems and how expensive it is to go on the new style system. And they said they got 30 some money in a pot. So I spoke to our practice manager, who then rang and said there's only about 30,000 in the pot. Well, for instance, for us to get out of our current system is about 14,000, and then you've got to pay to get into the new system. So going to this system where you've got, you know, press 1 for this, 2 for that would be brilliant, but funding it is quite an issue. So that's one bit. So yeah. I'll try not to hog the whole meeting, I promise. But the other thing was, you were talking about surveys of how patients use the system and make appointments. Just to say, at the moment, myself and some of my colleagues, one who's very savvy in terms of doing questionnaires, we're trying to do a question, or we're working through it, a questionnaire on how patients communicate which groups need more help than others and what we can do. As soon as I've got anything, I'll bring it back to the meeting.
That's excellent. That's great, because that's really good insights for, you know, for the whole of the system.
Yeah.
So I will take up, because I think I think Alice was probably taking that action forward in the points that you raised about.
That's right, because Alice gave me a number and I gave it to our practice manager, but there isn't a lot of money to help.
Yeah.
And getting out an existing contract is a nightmare.
No, I take that point. So I will just connect up with Alice. I know she was taking that point forward.
I'll shut up now.
No, not at all, Alan. Not at all. You keep us on the straight and narrow. So we've got Pauline saying that you can't access medical records from your GP practice online.
That's correct, yeah. I can't get them at all. So should we be able to? Should they be there for us?
Okay, so I'll sort of if you can can I communicate with you just directly if it's a specific practice one, and then we can just have a look at that for you, Pauline.
Thank you.
Okay, so I just can't see any hand raised. So I've got Anne. Do you want to come in?
Research for many years, I thought 30% response rate was very low, and that means 70% of the people surveyed didn't respond. And I wondered, you know, what do we know about them? Why wasn't there a second round carried out?
So, I mean, not sort of getting into the detail of research and the sort of statistical analysis, it's very much kind of not a numbers game. So in the research that we do, what Ipsos Mori would have done is when they start getting the information back through to people, they start analysing that and taking what the key themes are. And I mean, the interesting fact is that when you're doing research, that you don't usually have to get feedback from a huge amount of people to actually understand if something's going right. That comes through quite quickly, and if something is wrong, that comes through quite quickly. So they build that up over time, but I would say within the first few hundreds coming through the analysis, I would say, because it happens in our research, that probably the findings, even when you go into the thousands, you still have those key themes coming through. It's just really what happens with statistics. But usually for a lot of these things, you know, 4 to 5%, and this goes for all research, is often classed as a very good response. And it's more about whether it is representative of your patient population than being a sort of numbers game. So, you know, I take your point. It's just you know, once it goes then into statistical stuff, it is about more important that it's a representative from your patient population. Kirsty, I've got your hand up.
I was just going to add to that Shanaz had mentioned that the 30% was kind of the same as nationally. So we're not an outlier in terms of the response rate at all.
Yeah, lovely. Thank you. Thank you for that. So I've got nothing else in the chat box. And so Paul, your hand is raised.
Yeah, I did notice that on all the statistics, LLR was below national, which seems a bit surprising because part of national includes places like London, which are, well, a lot of big cities, which are reputedly dire for getting any GP treatment. And I think we were under the impression that Leicestershire wasn't that bad. So it's quite okay. It's a bit marginal, but have you got any thoughts on that?
I mean, in terms of the comparison, then I guess the facts are there in terms of where you compare across the board that we do perform lower in those areas. I think what we are concentrating on now is really looking at those practices who are some of the lower performing practices, because what we're experiencing is that those practices that are really experiencing problems, that they are dragging our overall scores down. So it's very often that the bottom 10, 15, 20 practices do need the biggest support, and therefore are almost skewing our figures on when we compare to the national data. So the approach that we're coming, so that we don't have this situation for next year, is really looking carefully at the practices that are in greatest need, supporting them and working with them so that we improve that situation. Andy?
Thanks, Sue. Yeah, I think that's a really important point, because what I'm not sure about is whether the Ipsos Mori survey has broken it down into sort of place level or even neighbourhood level. Did it do that, Sue?
Yes, it did. Yes.
Yes. So we have that data to work on, and presumably there is variability across the whole of LLR.
Yeah,
so although the story of what we're looking at does paint sort of a picture of maybe lower than national average, it's important to bear in mind the context of which we're looking at, because across LLR we've got quite significant variability in the challenges that we face. And so, some part, I'm not saying that this is exactly where the problem areas are, but for example, you've got some pockets within the city and the county where you may have unique challenges for those practices and their populations, where English as a first language may not be a predominant situation, and you may have unique cultural challenges that perhaps are not evenly distributed across Leicester, Leicestershire and Rutland. So that we've got to look at the individual pockets and work out why some areas are performing better than others, and try and really get on top of that and drill down into that data and try and lift the whole of the picture for when the survey is repeated, hopefully.
Yeah, lovely. Thank you for that, Andy. So Jane, would you like to come in and ask a question?
Yeah, sorry, I didn't know how to raise my hand to.
No, it's all right.
Hi, my question is, how do other practices manage to book appointments online for particularly such things as smears and maybe healthcare assistant appointments, because you can't be given a 10-minute or whatever it is slot for different sorts of appointments, because obviously some of them take a lot longer. So at our practice, you can book appointments online for the GPs, but then you would phone to make an appointment with an HCA or for a smear or the sorts of things that may take longer. And I was just wondering if there is a way of enabling those sorts of, because you don't know how long you're going to need. If you need a certain thing, you don't know how long it's going to take. I just wonder how other practices manage to deal with that.
So, Andy, I don't want to put you on the spot, but do you want to come in on that one?
Yes, that's fine. I mean, I think one of the difficulties is that each practice has its unique setup of how it manages appointments, and particularly with the online component, there has to be the workforce and the system behind that online booking system to be able to back it up, if you like. So practices will probably, because not everything is booked online, and we still get a lot of people phoning up through the phones, we've still got to meet that sort of demand. So what practice may be doing is they may be streamlining the online appointments for certain types of appointment at the moment, whilst things are kind of in flux. So it may be that that you may find that some practices are able to facilitate that, but other practices might not be, but then they might be doing things that another practice isn't. So there is variability across how the online booking system is being rolled out or being uprated, if you like, as the number of people that come through, and that will be determined partly by yourselves as PPG members to kind of shape and mold. Well, actually, we could really do with online booking for this particular group of patients. Is that possible to facilitate it, etc. Bearing in mind, though, obviously that there has to be the workforce behind there to be able to fulfill those appointments when they're booked. Does that sort of help sort of paint the picture for you there?
Yeah. Yes. Thank you very much. Thank you.
Thank you, and thank you for that question, Jane. So, Andy, I'll come over to you now, if I may.
Thank you, Sue. So this section is really building on what Sue has been talking about in terms of the various challenges that primary care and general practice in particular are under. We've talked quite a lot about the access and telephone system, and we'll come back to that in a bit. But really, when we've looked overall at the whole of primary care and general practice with a sort of main focus, because obviously when we talk about primary care, we're not just talking about general practice, we're talking about other parts of the primary care team, which would include optometry, local pharmacies, community physiotherapy and therapy services, etc. So looking at the challenges that we've got based on a lot of various information and data that we've collated through patient feedback, groups like yourselves, staff feedback, practice feedback, CQC, various quality dashboards that we run and keep an eye on, and then software intelligence through networking and discussions. We know that there are sort of 4 main areas that we need to be focusing on, and we are focusing on as a system to try and help the challenges, address the challenges that general practice and primary care are facing. So we've talked a little bit, we'll start with probably access, because that's what we've been talking about a lot. So you can see this sort of cycle of things, they all kind of link in with into each other really. But we've got access and infrastructure. Now, obviously, there's quite a bit of variability, as we've alluded to before, in how general practices operate their telephone systems, but also how they operate their appointment systems, and there are strengths and weaknesses to that. Obviously, one of the big strengths to that is that each practice can be responsive to its local needs of the population, and in particular, having a good, strong, and well-functioning PPG can help influence that sort of system. If you've got good links with your local practice, but at the same time, one of the counter side to that is it's hard for us to make sweeping changes across the whole of primary care to say, if we do it this way, this will make things better, because it won't necessarily, because we've got very hyper local challenges and issues as well that need to be addressed. And this is also a challenge because we've got a lot of backlog and challenges with the local hospital system secondary care, and that is also putting additional strain and pressure onto general practice. For example, if you are waiting to be seen at the hospital for something and you're on a long waiting list, then you may attend your general practitioner or try and get an appointment maybe several times in a year, whereas before you might not. So you've got additional level of support that's required through the process whilst you're waiting. So we're seeing an increased demand or requirements for patients to be able to try and use their GP services, as well as obviously those people that have put things off for quite a while, trying to do what they were told, obviously, which is protect the NHS. So we've got a sort of a mixture of reasons for why demand has risen, and in many ways, because of the nature of the pandemic and how there had to be such a transformational shift in the way that general practice was working, in many ways, things have improved in some certain aspects of the service. So, for example, the text messaging and the information transfer between patients and their general practitioners has vastly improved. So you don't have to necessarily wait for a letter anymore. Things can be sent straight to your phone via text. You can text information in. You can potentially email it in. All of this has really accelerated in recent years. But because of that level of responsiveness and improvement in that service, for example, also you're not having to necessarily always wait in a packed waiting room full of people coughing and spluttering. You may be able to have a more remote element if needed, or if appropriate. Then that is a more responsive service in some respects. But the problem we've got, obviously, is that there's only a finite number of people working behind the scenes to address all those needs. So all of this has knock-on impacts into access. We'll come into that a little bit more detail on the next slide, but the next area we've got to look at is integrated delivery models. That's sort of a fancy way of essentially saying trying to bring care closer to home. So trying to improve the way that traditionally, where you would perhaps go up to the hospital or go to another service and have to travel quite a distance, trying to bring some of that care into the community where it will be perhaps more appropriate, more suitable for patients and citizens to be able to get the care they need closer to home. And that's a transformational change and a shift in culture that is trying to happen at the moment. But it's challenged by all of the additional issues around the post-pandemic type situation we are facing. The next is quality of care and an equity of outcomes. So essentially, this is about trying to make sure we have some form of reduction in the variability that we see across the whole of general practice in LLR, and that there are some unique challenges within certain places. So when we talk about place has been, there are essentially 3 places in LLR. We've got Leicester City, Leicester County, which used to be East Leicestershire CCG and West Leicester CCG, which are now one county. And then we have Rutland as a place in its own right as well. So we do see some variability, and what we want to try and do is to reduce that variability across the whole of the system. And the reason for that in particular is to try and address where there is health inequity, and we know where there are problems and issues, and this is where sort of co-design at local level will become increasingly more important, and where the likes of PPGs will become increasingly more important to be able to help guide local practices and local PCNs to be able to hopefully design services that will address the needs of the local population. And I think that is where we've got to kind of look at using all of the dashboards and the information that we get, all of the feedback we get from patients, to sort of triangulate all of this data and then help support practices where that are finding it challenging for various reasons. Some of those are internal and some of them may be external. So that's another area we've got to focus on, and we are focusing on. And then one of the biggest challenges we have is about our workforce, and that is a challenge nationally, but obviously in LLR we will have our unique challenges. We don't have the number of GPs that we need to be able to deliver the care in perhaps the old traditional model that we used to, but we do have an increasing number of the highly skilled workforce team that are becoming part of the primary care team as opposed to just general practitioners working. Now, obviously, they all have to be supported by someone because they can't practice independently, and the people that support them tend to be your general practitioners. So although the actual availability of appointments and access to the primary care team is increasing, you may notice that then it's not as easy to get an appointment with your GP per se, because they're supporting wider numbers of the team to meet a larger number of health needs across a wider population. because of the numbers. So we're having to sort of adapt to the workforce challenges that we are facing as it stands. So that gives you a kind of an idea about the sort of 4 main areas that we are trying to address, and we are addressing, and we're sort of working on these. But it may help you understand a little bit of the background as to why things perhaps feel a bit different, or why things are shifting in terms of the approach to general practice. So we should come on to the next slide, which I think is about access, hopefully. Yeah, so we all know the challenges of trying to get an appointment on the same day, and it tends to be the traditional sort of ring at 8 a.m. model. And this is really, really challenging. We did some work in our own practice looking at figures, because our telephone system is not the newest, but it's certainly not the oldest, and we can get data out of it. And interestingly, we probably get around about, on average, about 1,000 calls a day, and our practice is about 15,500 patient list. So you can imagine, you know, we're not huge businesses like BT or Sky or any of these other places that you sometimes ring, as I know you'll appreciate. But you think about the numbers of calls that are coming through. Now, granted, some of those will be repeat calls, etc., because people drop off the list. But you can imagine that that's an average. So we probably get most of them calling earlier on in the morning and first thing on Monday, and then they drop off through the week. So we need to do some work on helping people to even out the distribution of the calling. And even with a queuing system, the queuing system that we have will only go so far before it drops people off the list. So when people start ringing and you get engaged tones, if there is a queuing system, then it's probably reached, you're probably reached way down the queue before the queuing system won't allow you to even get onto the queue. So we can use some of the data to try and help even out some of the calling. And this is where Sue was talking about trying to find other ways in which we can get people to access the service. So use of things like online, use of alternative, ringing in for certain things, or use of perhaps text messaging and that type of thing for results, or different ways in which we can change the model of how people traditionally access their general practice. Now that will require, it might require new telephone systems, etc. But as Alan mentioned earlier, funding is a problem, because that will be different from practice to practice, depending on who's tied into which contract. And across the whole of the system, then all those contracts are asynchronous as well. So it's hard to actually establish a sweeping change across all practices. Those are the sort of things that have to be worked with at the hyperlocal level and with individual practices and their PPGs, etc. There's certainly an uptake of more digital solutions, which is good, but obviously not everyone can access the digital solutions. But I think this is where we need to be encouraging people that can do it to use that, so we can free up the space for those that can't, so that is easier for them to, we can get that equity of access for people. So we've also, what we also need to be doing and is happening across the whole of the practices across LLR, we're trying to support practices to direct patients where perhaps a GP is not their best option, to other local services to help share the load of the demand that's coming through. So we've got the likes of pharmacies, community pharmacies, and certainly you may find that your practice will suggest a referral to the local community pharmacy as the first port of call. Optometrists and opticians, local therapy services, mental health services, where we can people can refer directly to the therapy services themselves, but also be able to access urgent mental health help if needed. And there is an urgent mental health help access number for triage. And then we also have the use of urgent treatment centres and minor injury services. But again, one of the challenges with that is that we've got to make sure that people that turn to use these services are using them in the right way. I understand that people just need help when they want it and they need it, but sometimes these services get overwhelmed or challenged with perhaps cases or situations that they're perhaps not the best or the most appropriate service to be dealing with. So it's trying to kind of get people to the right services at the right times when they need it. And then we've got the increasing development of services at neighbourhood. And when I say neighbourhood, we're talking about sort of your local practices that work together, probably at sort of PCN type level, and also a wider place such as county, city or Rutland level, where we might be able to try and get services out to the community in a more effective way than they can at the moment, which will hopefully reduce the burden and the demand on the backlog of services that are in the hospital and secondary care. So we'll move on to the next slide, please. So the next area we talked about was quality of service across general practice, and we do know that there is variation, and we've talked about that. But try to understand that and the reasons behind it are really going to be key. And we are looking at that. We do have increasing ability to use population health data to be able to focus in and work out what is going on in certain areas at the neighbourhood level and also at the place level. And then we can hopefully co-design our services with our citizens in local areas to be able to partner with the practices and their PCNs to be able to reduce that and address the variation that we see. And this is something a little bit about what we talked about. I know we were talking about it in terms of access, but this is in other areas as well. So there may be unique health needs to certain areas or local neighborhoods that perhaps need very, very unique ways of addressing those challenges. And that gives us an opportunity to be able to look at that. And so at the moment, we need to be improving the quality of our coded data within practices, because as we put things onto the computer, it means that we can then look at the data in a more sort of rounded way, and it gives us a better idea about what's happening at the local level. So the way I would describe it is that at the moment our data quality in NLR is pretty good in comparison to some other places, and we're quite a bit ahead of the game when it comes to looking at population health. But it's a bit like one of the TVs, you know, you plug in and you try and tune it and you get this kind of grainy picture. You can kind of see what's happening there and we get an idea about what's happening. But the better the quality data we get in, then the picture becomes more and more clear, and it becomes more almost, we want to get it to that high definition state where we can really know what's going on, and we don't have to, we can extract that data and see it and then go and address it, rather than having to kind of keep going in and trying to understand the exact nuances of what's happening, because we can see sort of a bit more of a grainy picture. But we're getting there, and we're working on that and to try and really improve that, to get that intelligence. Where practices are struggling, we are working with them, and we always do that, but we're working with their specific plans to tackle the issues, and then hopefully, because we have the PCN footprints now, we can also help encourage them to work with other practices within their PCN to have peer support as well, and we do see that. And so we're looking at continuing that work, and as PCNs develop and mature, we'll see hopefully more resilience develop in general practice as time goes on. And again, this leads on to the final point on this slide, which is about supporting practices to be able to be sustainable. You know, we all know that it's challenging if someone goes off sick, or if there's a problem or something happens in a practice. And what as a system, we're trying to support those practices to be able to have good quality sustainability and business continuity plans, and helping managers to be able to stress test, you know, virtually, or to just give some challenges to say, what happens if this were to happen in your practice? What would you do? So that hopefully it will enable continuity of services to patients should certain eventualities happen, particularly around workforce, for example. Let's go on to the next slide, please. So delivery of care. So what is happening at the moment is that there's going to be a move towards something called an integrated neighbourhood team. This is essentially allowing all of practices and PCNs to be able to start linking with. We've got LPT down here, and that's essentially Leicestershire Partnership Trust, who deal with things like the community mental health services, but also things like the district nursing services, etc. So linking with the local authority services, and that will be different within each sort of neighbourhood area. But getting PCNs and therefore practices to work in an integral fashion with the real local services that are provided by the likes of LPT and local authorities, to really start to pull together some changes in service delivery for patients. And that will also be backed with what we're looking at doing is trying to support practices to find those patients that require additional care. So things like, we call it complex care model. So it's about identifying those patients and then trying to proactively plan for their care. So where they may have long-term conditions that are challenging, trying to avoid crises, trying to think for the future, trying to support them in those patients from being able to take ownership of their health and being able to know what to do in certain eventualities, etc. And then we're looking at where there are challenges for where people do come to the point where they need additional emergency help, then looking at kind of urgent responses for home health and care responses, and also those that are discharged, making sure there's checkups to make sure that they're getting everything they need. And this is going to become increasingly important if we're going to address the wider challenges that we've got of getting through the numbers of people on the lists that waiting for surgery and getting through all of the winter challenges, etc. There is, not to kind of go into too much detail, but there's work ongoing with formulating the 5-year plan for primary care. So that will hopefully be done in conjunction with practices and PCNs. And this is about more about what we're talking about, of bringing that care closer to home. So non-acute care, non-acute services in community settings as opposed to the hospital setting. And trying to make sure that we're sharing workforce, if we can, between different organisations such as secondary care, LPT, and trying to kind of make sure that we have we're trying to develop integrated services that are fit for purpose, closer to home, which is more responsive and better for patients. Then obviously we've got the backlog that we talked about before. We've got a lot of people with long-term conditions that need monitoring, plenty of people that require tests and reviews. We've got people where their long-term conditions perhaps need optimizing, and this all takes additional work. So we've got all of this going on in the background, as well as the acute need of patients that are coming through. Now the digital care we've talked about, but there may be new models of care for specific populations, such as children or care home residents, that you might see practice trying different ways of doing that, different ways of addressing that. So some people might put on a kids clinic, for example, or there may be, if you've got a large number of care homes, you may have a model of care that helps support the work that's needed to address the health needs of those particular populations. That will be different from practice to practice. We've got some practices that have a predominantly university population, for example, and then we have other practices that would have a very sort of elderly population, and we have others that might have particular cultural challenges that they need to address as well. Let's go on to the next slide, please. And then workforce and leadership. So I think this is where you can really help your practices and support your local PCNs, because I think the nature of how people access primary care is changing. So I think people really want to see their GP, and rightly so. But ultimately, I think we have to recognise that the primary care team is expanding so that we can, and they're supported by general practitioners. And I think that is where, you know, it doesn't always mean that seeing a GP is the right solution. There are plenty of highly trained individuals now within the wider additional roles that come through the PCN that will actually probably be more accessible and perhaps even treat your condition with the with a slight leaning onto almost specialism. So that is where it's going to be perhaps better for you to see a particular additional role staff member. For example, we have extended scope practitioners, mental health practitioners, etc., where that's all they do day in, day out. They only see those types of cases. We need to be able to support our workforce. We need to encourage people to be able to come into the professions, be able to want to stay as well, because it can be quite challenging and stressful. And I think that there's leadership programs that are going on, trying to kind of examples of things like where we're trying to upskill members of staff. An example would be career pathways for our healthcare assistants to do more work at the top end of what they can do. And all of this requires a level of support from senior clinicians, which, like I said, does increase the overall availability of appointments, but then does present the challenge of you perhaps can't do quite as much of the frontline stuff as you used to, because you're supporting more people across the board to get the healthcare delivered. And this is the next one is a bit of a challenge, because we want to make LLR an attractive place to work for people, but obviously the danger with that is that, you know, there's only so many people around the areas, and so if you make LLR incredibly attractive, then obviously, you know, we then shift the problem elsewhere in terms of workforce to other regions. So we need to be sensitive to that. And I think retention is a big one, as opposed to sort of moving people around. But certainly there's a workforce bureau that is set up now, looking at these sorts of issues and trying to really come up with innovative ways of encouraging people to continue to work and enjoy their work and feel like they are making a difference within the system. And there's finally, there's work going on with PCN leadership development, etc., across all of the PCNs, and that's happening now and will continue to do into the future. So I think that's probably enough of me talking. I think we're okay for time. I just wanted to say thank you so much for your support and input, because I think it's so vital, and it will become increasingly more obvious to you that I think, you know, a really good relationship with your practice and PCNs will help to co-design those services in the future that you will see slowly rolling out to the community. And I think that will be increasingly important. So thank you very much for all the work that you put in to support our practices.
That's great. Thank you, Andy. So I'll come to questions. What I will just do first of all is just so people know how to raise their hand if they haven't previously done. If you just go down and scroll your cursor around the bottom of the screen, there'll be a number of options that come up, and one is called reactions, which has got a smiley face on it. If you click on that, then the bottom box says raise hand, so you just use that. And we have had Bhaskar, you've patiently waited there with your hands raised. Would you like to come in?
Yes, thank you very much, Sue. My question is regarding, and my concerns are with the out of hours care, where somebody just goes to the walk-in center thinking they will get all the care that they need. They have to wait in the queue for a long time before they are seen, and then only to be told they cannot be treated there, so they've got to go to Leicester, to A&E. And again, there's a long waiting list there. So if somebody from the urgent care center was able to direct them, like, I mean, within a few minutes to say, like, you should go to A&E in Leicester rather than wait there, and then get this response.
Okay, thank you for that question. Andy, do you want to come in?
Yeah, certainly. Thanks for that. I think it's such an important point, because I think there's so much time that's wasted in multiple services that goes around both the patients, but also for the people working in those services when people end up in the wrong place. And I think that is something that, it's not their fault. It's just one of those things that happens, that it's the challenges of what we'd probably just call high quality care navigation and perhaps smarter care navigation. And I think that it's a tricky problem to get right, because to do so, you almost need someone to have partially assessed the problem to know where it has to go. So there are two main challenges with that. So the first is that we need people, and I know it's a bit controversial, people don't like it, but we need people to be trying to give an overview of their problem ahead of when they're arriving. And so you may hear that at sort of at practice level, where people who've been trained in care navigation may be asking you what the problem is, and it may seem like, well, why do I need to give that information out? Well, part of the reason is to try and avoid this problem of where people get directed to the wrong place. So it's sort of trusting in the process to a certain extent, but also then making sure that those people are skilled enough to direct people to the correct place. And I think there is training and development work that does need to go on in order to help facilitate that. Because at the moment, when it's hard to get through to one place, and numbers of, where I think more people and more services that you could access, you need better quality navigation, and that is something we've just got to work on as a system. But I think the partnership element for patients is an understanding of, if you give that information across up front, it makes it easier for the navigator to be able to direct you right place. So that helps save you the hassle of being sent one place and then going to the wrong, and then having to go across town to A&E where you could have gone in the first place potentially.
Thank you.
Lovely, thank you. Anne is asking in the it's quite an interesting news this morning. So what's LLR's views of restricted applications to medical schools, and obviously we've heard this morning on the news the government response to the amount of applications that are coming in to train as GP practices. So it's quite a timely one. But Andy, have you got a view at all on that? Again, I don't want to put you on the spot, but
that's all right. That's all right. That's fine. Look, I mean, I think there's, Anne's question is what's LLR's view?
Yeah.
Obviously, I have my own view. I'll not necessarily share that today here, but ultimately, the challenges we've got is it's a political decision in some respects, because of what the funding required to train people through medical school. We know the challenges that are there in terms of getting people through medical school even, and the numbers of people that looking perhaps not for the same traditional careers that they once had, in the sense of settling into one practice and just staying there for the whole of their careers. People have to work for longer now in their careers, and so they look to develop portfolio careers, or perhaps they look to try and slow the pace down a little bit, particularly through the intensity of which we're all working in now. So I think that even though the numbers coming through, you're not necessarily one person that comes through medical school does not equate to necessarily one full-time doctor at the other end. And I think that's probably the thing that is also not helping the situation. But in terms of what we can do about it, I think locally that's probably out of our hands to a certain extent. But what we can try and do is work on the when people come through, making sure that they are supported to feel like they want to stay, and making sure that they feel satisfied, that they are supported through their employers, making sure that they in LLR, making sure that we've got good support networks and clinical networks to be able to allow people to feel that they're making a difference, and to learn, and to feel like they're in a good place in LLR, which I believe they are. It's just trying to get that message across, and also making sure that people feel that. So it's a challenge. It's one that we need to sort of manage the effects of it, rather than try and kind of address the underlying reasons for why that is the case. It's one of many things that are a challenge challenges for us in LLR.
Thank you, Andy. And thanks for the other questions that are coming through the chat box. Just Anna's asked in terms of the feeding back on hospital services. So, I mean, there's different ways. I mean, this forum is a great forum, but obviously if it's more personal or complaints, then I've put the details in the chat of how that can happen. But also Howard quite rightly has also put details of Health Watch Leicester and Leicestershire, and then also there is a separate Health Watch for Rutland, so that's an important outlet as well.
So there's another one that you may not be aware of as well. It's not, I wouldn't suggest going to your GP to raise the issue with the hospital necessarily, when there are other routes for you to be able to do that. But should let's say you're in consultation with your general practitioner, and it turns out that there's an issue that perhaps needs escalating, then we as GPs have the ability to be able to escalate that as well through something that we have set up to be able to help facilitate better communication across between our hospitals and general practice, but also then to raise any risks. But sometimes you may find your GP might ask for your consent to do that, because it requires a consent box to be ticked. So it's not something probably for you to be thinking, right, I want to do this and act this way, but it's just something to be aware of, that process is available, and that your GP practice can escalate things as well, should they feel that is something that is suitable and appropriate.
That's really useful. Thank you for sharing that, Andy. And thanks for those all those questions and answers. So now we'll come to Mel.
Hi everybody. So yeah, what I was going to talk through is kind of what we're doing around our kind of winter communications and engagement plans. So kind of what we're autumn and winter. And so as part of that, I'll kind of go into some specific campaigns that you will see. And so I will pick up on your point from the chat, Sean, you know, about that previous campaign that you've seen. So could I have the first slide? Thanks. So what we're doing around autumn and winter, so there isn't kind of just one winter campaign this year, because there's lots of campaigns that are being produced. So some of those at NHS, some of them will be local authorities, some national ones, some local ones. So rather than kind of reinventing the wheel, the plan is that we will bring together all of those individual campaigns under one umbrella. And so there's going to be kind of a central online hub for all of that, which is going to be on our the Leicestershire Rutland Health and Wellbeing Partnership website. So that's kind of a brand new website. So the Health and Wellbeing Partnership is basically about how the NHS works together with other organisations in our local area, so like local authorities, the voluntary sector, etc. So that's kind of a new website that we're going to use to share all of the information and bring it all together. We'll also be kind of sharing details regularly about what's the next campaign that we're focusing on, and kind of providing partners, practices, etc. with toolkits to allow you to be advocates basically for the campaigns that are out there, and obviously kind of through our social channels as well. We'll kind of tie all of those together. And so, kind of the reason kind of we're doing it in that way is, we want to avoid duplication. There's lots of, we don't want to be all doing the same thing and competing in the same space, for kind of people's attention. So it kind of avoids that. It also kind of means that we can link up things. So for example, like mental health, you've got kind of NHS and probably local authority, and voluntary sector all working on that. So it's about, kind of how we tie everything together. And of course, it also makes sure we reach more people, because we're all sharing the same campaign. So it means it kind of the reach is bigger, basically. Have the next slide, please. So this is just to, to give, I'm not going to kind of go into detail about all of this, but this is just to give you an indication of the range of different winter messaging that will be part of that campaign. So I think there's probably a few more that are missing off here. So, there's kind of loads of things that we need to cover. So that was just kind of to give you an idea of the scale of it, basically. Could I have the next one, please? So these kind of messages is a combination of things, really. So one, some of them is about educating people about how to prevent illness and injury. So, for example, there was kind of one of the messages there was about kind of, you know, slips, trips and falls. So it's kind of, building people's knowledge basically about how to prevent things from happening. Then there's an element of, you know, supporting people to look after their own health, and what they can do if they need a little bit more support with that. And then it kind of comes down to, you know, kind of awareness of, you know, local services, what they are and how to access them. And then kind of I suppose kind of the bottom 2 points, really, it's about there's some services that patients wouldn't necessarily access directly. You know, you wouldn't kind of book an appointment at them, but if you, for example, went into a hospital or, you know, went to your GP practice, you might end up, you know, you might be referred to them. So, you know, some of it is about kind of raising awareness of, you know, what you might expect, you know, particularly if care might be delivered in a different way to, you know, what you might have seen previously. So there's kind of a few different strands to it, basically. So can I have the next one, please? So I just want to talk to you a little bit about one of the campaigns, which is probably pertinent to this group, which is basically about it's a GP practice campaign basically, and we're calling this Get in the Know. So it's about kind of getting in the know about, you know, how GP practices work nowadays. So that will include lots of messages about the practice team. So, you know, kind of all of those roles and, you know, what they're there to do, you know, different ways of getting in touch with your practice, you know, online services, you know, receiving care in different ways. Will include something around the enhanced access appointments that Sue talked about at the beginning, and probably things about, you know, things like, you know, instructions for people, you know, like repeat prescriptions, for example, would be one of those examples. And then, so as part of that, which we will also bring this out into a separate kind of mini campaign. There'll be something about supporting people to look after their own health conditions, so not kind of, you know, not long-term conditions, but illnesses, minor ailments. And so, but rather, you know, originally, and this is kind of comes on to your point, Sian, about, you know, the previous campaign that you saw. So we've moved away, actually. We were going to kind of do a bit more focus on, you know, these are the individual ailments and this is how you look after them. But our focus now is about, you know, rather than kind of going into each individual one, it will be about, you know, generally, you know, there are lots of minor ailments you can look after yourself. And, you know, if you need a bit of support, these are the places where you can go to get that, which would be, you know, 111 online, the NHS app and local pharmacy. So some of the kind of previous work we will probably incorporate into this campaign, but it's not going to be kind of a key feature. And then there's another bit of the campaign that we will pull out from the main campaign, which is about, you know, if you need urgent help. So about, you know, kind of, you know, when to use NHS 111, so the kind of the phone part of the service rather than online. And, you know, so we might use this brand for other things in the future, you know, where we want to you know, talk to people about, you know, different services, for example. So like mental health might be one of those examples. Could I have the next slide, please? So this is just a bit of a sneak peek, really. So this is not final creative at all, but just to kind of give you a flavour of kind of visually how this campaign might look. You know, the words, you know, need a bit of work still, but I just want to kind of, you know, kind of show you visually, you know, what you might see. But so, you know, we will, you know, when we've kind of got this all finalised in the next week or so, we'll, you know, we will send out toolkits, you know, so you can kind of, you know, see the final version of it. Next one, please. So, and this will just kind of give you a flavour of, you know, all of the bits that we will be doing, all the activities that we'll be using to promote this campaign. So kind of the things on the left are the, you know, the kind of things that you would normally expect to see from a campaign. So we'll have things on the website. We'll be doing work with the media, you know, social media. We're going to be doing some videos, you know, kind of with, you know, kind of interviewing clinicians, you know, talking about their roles. And there'll probably be something again similar about, you know, different aspects of using GP practice, you know, all kind of, you know, briefings for all, you know, partners, you know, from all different organisations, and, you know, and toolkits I've mentioned. But then in addition, we are doing some paid advertising to support this as well. So, on, social media and some of our other digital channels, there'll be some kind of outdoor poster advertising, and then there will be some printed materials available as well. And, to make sure that we can communicate this to, our diverse population, that, our content will have so things like translated materials, videos will have, voiceovers and subtitles in different languages, that kind of thing. And could I have the next one, please? So that was kind of the GP practice one. I also want to kind of let you know as another, I suppose, kind of an example of how we're going to be bringing lots of different campaigns together under the winter umbrella, is around World Mental Health Day. So that's coming up on the 10th of October. And that will be kind of like our first example, really, of how we will kind of bring together and curate, lots of different campaigns that partners are producing. So, for example, there's a new health and wellbeing service that is being, it's being relaunched. Things like crisis cafes that we're getting more and more of those. How to use the central access point. The local authorities have got some suicide prevention work going on, and there's also a national campaign as well launching around that same time. So again, we're going to kind of bring this together and summarize this for people, and put everything in one place so that that everyone can access it easily. And the next one, please. So COVID and flu. So this is just kind of give you a flavour of what's happening. So obviously, I've listed there the people that are currently being called forward for their autumn COVID boosters and flu vaccine. So eventually, the full age group is kind of people who are aged 50 to 64. But at the moment, we're just calling kind of 65 and over, plus those that are at risk with health conditions. So that is kind of changing regularly. So we have started our local promotion about all of this. And actually, can you move on to the next one, please? So yeah, we have started our promotion on all of this. We had a bit of a pause during the mourning period for the Queen, where we weren't really allowed to do very much. So, for example, on our social media had to be very kind of basic. But from last week, that's kind of started to ramp up again now. As part of the messaging, also we're telling people how to get the booster. So it's booking via the national online system or 119. Obviously, practices are inviting people who are eligible as well. But as with previous years, the message is kind of wait until you're invited. The next one, please. So this will just kind of give you a bit of a flavour for the local promotional materials. So again, we're sending kind of toolkits out weekly about these, and kind of explaining kind of what the latest position is. And I think some practices get that directly, but I think it also goes out as part of GP practice newsletters as well. But again, we've got some kind of advertising that we're doing locally around this. So we're doing things with the Sky TV network, radio, promoting on pharmacy bags, digital paid social advertising, lots of different things going on. The national campaign is a bit delayed. So the national campaign will be happening late October. So when our kind of it's worked out nicely actually that once our local advertising campaign has finished, the national one will be starting as well. And I think that was my last slide. So I'm happy to take people's questions.
That's lovely, thank you. So we've got Les with his hand up. Would you like to come in? I think you're just on mute at the moment. If you just go to the bottom of the screen and just unmute yourself in the left-hand corner.
Yeah, technology won, me nil. Yeah, I found that incredibly informative. Will I be able to print off some of the slides to present at a PPG meeting?
That's fine, yeah, as long as, so the only thing is said that the creative that included in there isn't final, so I wouldn't want you to kind of, that's been the practice, but I'm quite happy for you to, to share that with, with other PPG members. Yeah, very happy.
Yeah, I've found that a wonderful thing to do, it really is good. So thank you very much.
Oh, thank you. Thanks for your feedback.
Okay. Thank you.
Right, thank you, Les. So if we just look at the question, so hopefully, Alan, I think you sent your question about COVID boosters just as Mel was going on to that slide. So hopefully that has been answered now. Bev, do you want to come in? I think your query was just in terms of GPs allotting calls in shorter periods of time.
Well, yes. When you get in a letter saying your telephone appointment will be after 8 AM on such and such a date, it's really not useful for people without mobile phones. It means you're tied to sitting by the landline for the rest of the day. And I do think I know it's very difficult and they can't assess completely how long the phone call will take, but surely they could cut them down into shorter intervals, 2 hours or 3 hours.
So thanks for that. Andy, did you want to come in at all there?
Yeah, I think that's a perfectly reasonable suggestion. I mean, I think it's probably one thing for an individual practice to kind of get that feedback to them through their own PPG or to that practice, because obviously they'll have their own system about how they're managing that. But I think, people don't always think about these things, Beverly. I think, that when they implement a system, it's kind of the nuances of how that works out.
Yeah, it wasn't a GP appointment. It was.
Oh, okay. Yeah. But no, it's fine. But I think people, when practices or whoever it is implements a system, sometimes we need that live feedback to be able to make the adaptations to improve the service. So it maybe people haven't just thought about it about landlines in that particular place. So worth feeding it back, I think.
Thank you.
And Anne, thank you for your feedback. So your observation is there's some confusion over the double vac for COVID and flu. So clearly we need to unravel that and look how we do our messaging around
as far as I know, it's kind of where possible. Both vaccines can be given together. That's the national message, and that's the message we're giving. But I think it might depend on how. So if a practice is kind of delivering the vaccines, it might depend, how they want to work it themselves. So I think there might be an element of, individual practice, procedures, I suppose, rather than. I think that's just, as far as I know, it's you can have both together.
Yeah. Okay. Thanks. I mean, is there any sort of medical view on that, Andy, that you want to give?
Yeah, I mean, I think my understanding is that they can be given together, but that doesn't mean that from a practical perspective, a practice may or a PCN may not want to do that for various reasons, because it is it's a separate set of documentation and everything else, and the numbers when you go through it, it's relatively quick. I mean, you're doing a huge number of people when you're doing particularly flu vaccinations, so there is additional pressure on the coders, etc., to get that through. So it may slow the whole process down. So it may be practical elements for why that is, but there's also the element of sometimes there may be a little bit of nervousness about how people are going to feel after it. So perhaps practices are trying to be a little bit generous with their timing to make sure that people are not feeling a bit lousy after both the jabs. But I think those may be the thinking behind why there may be a bit of a delay. It could be for practical reasons or just a bit of extra caution. But I think the advice is at the moment that it's okay to give them together. I think that's right, isn't it, Melanie?
Yeah.
Thanks for Mel and Andy for that. And Pauline just come out, in terms of boosters, but you're still getting messages, although you've had them. And I think that's a combination of some of those will almost be national messages, some will be different providers at a local level. Appreciate it. It's not ideal. I suppose on the more positive side, I think it's really important, given that we haven't got that national push any longer, that the importance of this is still kept through the forefront of people's minds, because obviously, you know, society might feel that COVID has gone away, but it's a very real issue that is still with us. So I've not been managing our time very well, but I do think that it's been worth just going over on our timing, because I think there's been some really good stuff coming through. I suppose I will just ask the question in terms of any other business, anything that is sort of really matters to people, or if it's kind of ideas for next agenda items, you can either tell us now or do email Burge to collect those, because we always aim to make sure that we're targeting these meetings to what matters most to you. I can't see any hands raised, so there we go. We've got the PPG network meetings through to the end of the year, and we'll make sure that we keep up on then once we come into 2023, which I can't believe I'm saying that, we'll get those dates out to you as well. So if there isn't any other business, can I share, you know, my thanks to Andy's really. Thank you all for all the help and support that you both give to your practices, but you give to the whole health system. That's really appreciated. Thank you for your time at this meeting today, and thank you to our speakers, Andy and Mel. So have a good rest of the day, and as I say, we're always here if you just want to exchange any emails. Take care, everybody.
Thank you. Bye-bye.